Hello, everyone. My name is Meena Ramchandani. I'm an infectious disease physician at the University of Washington in Seattle. This podcast is dedicated to an STI review for healthcare professionals who are interested in remaining up to date on the diagnosis, management, and prevention of STIs. We are delighted to have back Dr. Olusegun Shoge, who also goes by Esso, join us for this episode. Dr. Shoge is a microbiologist with expertise in molecular diagnostics and antimicrobial resistance of sexually transmitted pathogens, and is an associate professor at the University of Washington. We are very excited to have him on this episode to talk about antimicrobial resistant Neisseria gonorrhea and surveillance for this organism.
Well, thank you. Thank you so much for having me.
Tell us a little bit about some features about Neisseria gonorrhea that make antimicrobial resistance such a concern. Like, for example, is there anything about the specific microbiology that makes this pathogen more resistant to antibiotics?
Well, thank you. That's an excellent question. So Neisseria gonorrhoeae has a very fascinating microbiology and probably explain why it's been able to sequentially, consistently, notoriously develop resistance to all antibiotics that have been recommended for treatment. First, there's the natural competence for transformation, which means Neisseria gonorrhoeae is naturally competent for transformation. It can take DNA readily from wherever it is in terms of the environment, where you have it in the pharynx, where you have asymptomatic infection, and the patient will not even know they have it. And then they can carry it for 16 weeks and not even know it's there unless they happen to go in for screening and then they test. So during the time that Neisseria gonorrhoeae is there in the environment with other commensal Neisseria species, all the bacteria, it provides a good opportunity for it to pick resistant DNA, and then it can just incorporate it into its genome. And this has been used to explain the mechanism of reduced susceptibility to cephalosporin due to the penile mosaic. And when we talk about commensal, these are natural flora. These are bacteria that are there, not causing infections. It's there in your pharynx, but Neisseria gonorrhoeae that is pathogenic interact with it and is naturally competent, can pick DNA, incorporate it into its genome, and then become resistant to the antibiotic. Also, acquisition of antibiotic resistance by genetic mutation is very common in Neisseria gonorrhoeae. For instance, mutations in the 23S rRNA confers azithromycin resistance. And there you have two types of mutations that are very important. The C2611T mutations confers low-level azithromycin resistance, and the A2059G mutation confers high-level resistance. So Neisseria gonorrhoeae is having fun. And why is it having fun? Wherever it is, either in the rectum or in the pharynx, it's developing and acquiring mutations that will lead to resistance to the drug we're using for treatment. Also, the selective pressure from antibiotic use. Some of our standard of care practices are contributing to selection of Neisseria gonorrhoeae antimicrobial resistance. For instance, someone comes back for a gonorrhea test of cure, and we use a very sensitive nucleic acid amplification test, NAT, which actually, guess what? It's so sensitive that it detects both viable and dead organisms. NAT does not discriminate between viable and dead organism, or just remnant nucleic acid material. And so if NAT detects a dead gonococcus, the clinicians will still treat the patient because they must treat everyone that is positive for Neisseria gonorrhoeae. We've shown in a study that we published in Seattle that previous use of azithromycin, which is a macrolide, was actually significantly associated with azithromycin-resistant GC. So a patient who has been previously treated with azithromycin, either for chlamydia or other STI like MGen, for instance, and they come back when they have gonorrhea, we cultured the Neisseria gonorrhea, then we perform antimicrobial susceptibility testing on the isolate. What did we find? We found that those isolates have elevated minimal inhibitory concentrations to azithromycin. We found that the risk of azithromycin resistance increased with more recent and more frequent use of azithromycin. So I've talked about asymptomatic infection is a reservoir of infection and also of antimicrobial resistance in Neisseria gonorrhea. But something that is not always talked about is Neisseria gonorrhea actually can produce biofilm. And the biofilm is just like a protective layer that will protect the bacterium from antimicrobial agents. So that also contributes to antimicrobial resistance. Another important one that I want to talk about is Neisseria gonorrhea is a master of immune evasion. It's a master of disguise. So you can have gonorrhea over and over again, and the reason is because Neisseria gonorrhea can evade your immune response so easily because it has found a way to do that through phase variation as well as antigenic variation. So it can change the structure, it can alter its surface protein to evade the immune response. So the target will not see it at all that is there. So these are all contributing not just to repeat infection, also contributing to antimicrobial resistance in Neisseria gonorrhea. So also acquisition of genes, acquisition of plasmid. We've talked about TET-M gene, which actually the origin was streptococci. The origin of the high-level tetracycline resistance in Neisseria gonorrhea is a non-Neisseria species, Streptococcus, gram-positive bacteria. And we just expect that over time, Neisseria gonorrhea will naturally, because it's just a way of life, that's just normal to them, to find a way to develop resistance to all antibiotics. So the microbiology is very, very fascinating. And another thing I should talk about is the linkage between antibiotic resistance and fitness. Some of the resistant genes we're talking about, like the GRA, you would think the acquiring resistance could either be a fitness advantage or be a fitness defect. Some of those genes actually confer fitness advantage, just make it happy and just make that strain to continue to disseminate and to spread. It doesn't die out, whereas some genes actually make Neisseria gonorrhea to die out. But some of those genes, even after we've withdrawn them, we are no longer recommending them, like Cipro. The resistance will not fall down completely. It's because they're there and they are stable. Some of those genes, resistant genes, do not confer fitness defect, but they actually confer fitness advantage. So they make Neisseria gonorrhea to continue to proliferate and just have fun and continue in the population.
That's fascinating. So it sounds like there's a number of different ways that the microbiology of Neisseria gonorrhea contributes to antimicrobial resistance, including snatching up DNA from other bacteria, the overuse of antibiotics, the biofilm formation that makes it difficult for antibiotics to penetrate, and then changing morphology of the surface so that the immune system really can't recognize the pathogen. Has there been a concern among the scientific community of general antimicrobial use in the STI field? Why is that?
There has been a lot of concern, and there will still be a lot of concern. The infectious disease community, the STI field, particularly concerned why, of all bacteria STI pathogens, Neisseria gonorrhea has actually done a great job for decades. That we've never been able to keep one antibiotic for treatment of gonorrhea for decades. Neisseria gonorrhea has always found a way to develop resistance. And that have actually brought up the question of what are we doing in terms of antimicrobial stewardship? What are we doing in terms of STI management that could be contributing to the selection of antibiotic resistance in Neisseria gonorrhea, the use of tetracycline for treatment of NGU, for treatment of chlamydia, for instance, we found in Seattle right now, after the introduction of doxipep, Neisseria gonorrhea tetracycline resistance, not just the chromosomally mediated, but the high-level tetracycline resistance that is on plasmid, the TETM resistance, is the predominant resistance in Seattle right now. And so we did an analysis where we looked at when did this start. It predated the introduction of doxipep. And so that raises the question, the use of tetracycline for NGU, for chlamydia, that was around the time we started seeing the increase. However, the increase actually skyrocketed with the use of doxipep, and now we are 65% as of June of last year. By the end of last year, probably will be above that. I'm talking of 65% of not just low-level tetracycline resistance, but high-level resistance. So the reason why there's concern in the STI community is because the overuse and misuse of antibiotics causes a selective pressure that leads to the development and spread of antimicrobial resistance in Neisseria gonorrhea. Some of our standard practices, like epidemiological treatment for STI, you treat contact to STI. At times, you treat all the partners, you treat everyone, even without the result. It's not automatic because you slept with someone, then you must get the gonorrhea. But because we do empirical treatment and then we do epidemiological treatment, then we wait for the result. Oh, okay, maybe you have chlamydia in addition to gonorrhea, but what happens if they come back negative? We already treated them. So that is also causing selection of antimicrobial resistance in Neisseria gonorrhea. Treatment of asymptomatic infections, we're not sure. Are they viable or are they not viable? But will patients be happy that when they have infection, you are not going to treat them? I don't think so. Some European countries are actually moving away from treating asymptomatic infections, and then is also causing some discussion in the US. Should we be doing that so as to reduce the selective pressure and control antimicrobial resistance in Neisseria gonorrhea? Our test of cure is guided by nucleic acid amplification test positivity. So if someone comes back and they've not completely cured the infection, or they've cured the infection, all that is there is just dead organism or remnant nucleic acid, we'll still treat them. We'll think they have not been completely cured, even though the culture will be negative, but the concern is culture is not very sensitive compared to the NAT. So we treat patient during test of cure if they are still positive, but we don't have a viability assay. And when I talk about viability, there's an assay that tells you, oh, gonococcus is still alive. And so they can transmit that gonococcus to another person. But the gonococcus is dead. If we have the viability, it tells us, oh, gonorrhea is dead, but it's completely dead. Don't worry about it. We don't have any FDA approved assay to do that. Excessive antimicrobial consumption in specific population is a big problem. Like MSM that are on HIV PrEP, you test them so often. The more you test, the more you see, the more you detect, and then we'll treat. Then global disparities in GC surveillance. In the US, we've been monitoring antimicrobial resistance since 1986. And there are countries of the world where this resistance is emerging and they don't have the resources to do that. Whereas for us, that's why the scientific community is concerned that the highly resourced countries have all the money to do the surveillance, but the low-resource countries do not have the money to do the surveillance. But when it comes to the emergence of resistance, history has taught us over and over again that it emerges in in Southeast Asia, and other countries, not in the US. Shouldn't we be monitoring the emergence of resistance in low-resource countries? I think that's what WHO and CDC have been trying to do, but that program, probably the future is uncertain right now in terms of the funding to continue that activity. Also, the impact of the use of antimicrobials, not just Neisseria gonorrhea. What happened to Staph aureus? What happened to other things? the excessive use of antimicrobials to treat dead gonorrhea. I'm not saying all of them are dead, but some of them are dead. But we don't have a way to know whether they are dead or they are not dead. And that includes doxypep as well as asymptomatic treatment and other use of antimicrobials. So antimicrobial stewardship is critical, which some European countries are actually doing a lot to address, but I think it's going to take time. And we need perspective of the patient as well. I think this needs to be shared decision in terms of whether a patient will be willing to wait for you to actually get a test result back, if they are contact to gonorrhea, if they will feel okay to wait. And when it's negative, you don't need to treat them, but I think they come back, we treat them, and then when we get negative results, I'm not sure whether we call them and say, hey, sorry, you actually didn't have gonorrhea, but we've already treated you anyway. So these are some of the concerns in the field of STI, why some of the things we're doing, it's contributing to the problem of antimicrobial resistance in Neisseria gonorrhea, and we need to think about gonorrhea control and prevention from the lens of antimicrobial stewardship.
Yeah, it really speaks to the importance of antimicrobial stewardship. And that's not only for STI pathogens, because if Neisseria gonorrhea can grab resistance from other bacteria, it's antimicrobial stewardship in general for all infectious diseases. And I wonder if the lack of antimicrobial stewardship in some countries contributes to increased Neisseria gonorrhea resistance that we're seeing in some other countries that will eventually most likely come to the U.S. as well.
I totally agree with you. The use of antimicrobials are now regulated in many low-resource countries. And so you can just go to the pharmacy, and they call it chemist. And all you just say is, I have this painful urination, I have these symptoms, and there's a tap running here. What can you give me to help me? And then they tell you how much money you have. And based on how much money you give them, and that's what they sell you. So when we talk about antimicrobial stewardship, there are places in the world where we don't have any program monitoring that. But also we should talk about the U.S., where we have a robust program, antimicrobial stewardship program. But our practices, standard of care practices, is also contributing to the problem. So I think we all need a more coordinated approach to making sure our antimicrobial stewardship actually help in terms of reducing the excessive use. The argument about doxypep, for instance, is doxycycline is used for other things, acne and all the rest. It's not just the little we're using to prevent STI. It's not going to be causing the problem. So I think overall, like you said, for all infectious diseases, having an holistic approach to look about how we can control and reduce our use of antibiotics. Like a report from CDC said, 30% of some of the prescriptions are unnecessary. Even 70% we can reduce it. So that's a lot of antibiotics we're using. And I agree with you, in low-resource country, where the resistance actually developed, we're not doing enough. And the little we're doing now with WHO, I'm concerned that we may not even be able to do it, which will put us in a very bad situation in terms of what's going to be the future of preventing the era of untreatable gonorrhea, which is what we really want to avoid. And what we do in the U.S. is not enough to stop what happened in Vietnam, in Cambodia, just investing into work over there, working with folks all over the world, in Africa, in Europe, just to have a global coordinated effort to prevent the era of untreatable gonorrhea. That's what we should be doing.
And from a pathogen perspective, it makes sense from Neisseria gonorrhea's perspective, because if some resistance actually increases bacterial fitness, then it will just persist in that resistant form.
I agree. Yeah. From the pathogen perspective, it makes sense. But the pathogen doesn't want you to take any action to prevent that. And that's where we really need to face the reality that the pathogen is actually outsmarting us. And we need to actually outsmart the pathogen. And the way to do it is to actually invest to catching it where it develops and stop it before it spreads to other parts of the world.
I can see why you study this disease. It's very fascinating.
Yes, I agree. It's my bug.
I just want to say thank you, Esso. That was an incredible review of antimicrobial resistant Neisseria gonorrhea and the surveillance that's being done for this pathogen. This podcast is brought to you by the National STD Curriculum, the University of Washington STD Prevention Training Center, and is funded by the Centers for Disease Control and Prevention. Transcripts and references for this podcast series can be found on our website, the National STD Curriculum, at www.std.uw.edu. Thank you for listening and have a wonderful day.